Hello, everybody. Greetings from the Thalassaemia International Federation offices. I would like to talk to you today about thalassemia-specific registries. In this cartoon, we're trying to show that there's a lot of data which has to be gathered that will affect the patient outcomes, and they include clinical data, laboratory data, pharmacy, everything that's gathered in research. And all of these things can actually guide policy and service development. How do we gather this information? There are two kinds of registries, if you like. One is a patient registry, what we call, which is a collection of clearly defined set of data. Which most certainly will include demographic data. It will certainly include diagnosis and other specific characteristics of the patient population. And then we can have an electronic health record, which is a digital version of the patient's paper chart. And electronic health records are real-time, patient-centered information that is actually gathered over time. Let's go back to what is a registry. A registry collects aggregated data. Data which may produce information which is not necessarily available in all medical records. It's different from just a simple index. It may include demographic data. It may include diagnosis. It may include other information, but it's not just an index. It's not just a simple list. And it certainly contains more extensive data. It's different from an electronic medical record since it's less complex. And it includes a much more limited data from each patient. And however, at the same time, if you do have a full electronic health record, then you can derive registry data, define the data that you want to extract for a registry from that electronic record. Let me give you some examples. According to the UK hemoglobinopathy registry, the importance is to improve the management of the patient services. This is primary number one, is to help us plan for the future. If we know how many patients we have, where they're located, what's the quality of our services. And one way to guess the quality or understand the quality is by looking at survival and patient age distribution will give us some of that. Here we have an age distribution of patients which is over the age of 40. This means that there is good management going on. And we can actually locate and within a country find the hotspots where the patients are located and there plan and locate our services. I'm not going to give you a detailed description of this list of these 10 key principles. It's just to show you that in the European Union, at least, there has been, if you like, a lot of thinking going behind registries. And I only wanted to point out the last two, 9 and 10. Patients are an active stakeholder in this database. No patient is on it without his consent. And patients and registries are instruments not only to empower policymakers and people planning services, but also the patient communities themselves. So we all have a share in developing a registry. What kind of data can we extract, if you like, from a registry? It depends on what we want, on what the planners want. But certainly carrier frequencies from which we can calculate the expected affected births, Therefore, how many births how many patients are we expecting to be added every year? I spoke already about the age distribution of patients. What about the ethnic and religious structure of the population, the migrants, which may affect the incidence and the prevalence of hemoglobinopathy patients? How many patients with each syndrome? What is the real prevalence? And how do we micromap each country? And of course, the data collected will depend on the quality of the data. Is it true? If we put in garbage, we get out garbage. And we expect that those entering data are actually consistent, are actually caring about the quality and the accuracy of the data they put in. Just another example here of France, data from the French registry, again, indicating the hotspots. Where are most of the patients located in France? And therefore, where would I develop specific services? So, in addition to everything else, a registry will help research. It will help clinical trials. It will help clinical research. And all these factors have to be considered. And therefore, a center which has a proper registry is much more able to enter and be effective in research. So a lot of information has to be stored, has to be gathered, and there should be good automatic data management and good statistical support so that all this data can be analyzed properly. Now let's move now to the electronic patient record. The electronic medical or health record stores more clinical information than a registry. It has a lot of, if you like, features which will help good patient management. For example, it will satisfy and facilitate networking between centers. The patient that lives in the periphery maybe will have data coming to and fro a reference center, for example, with his consent, of course. And then we can have laboratory data, we can have a PAC system so that MRI and other imaging can actually be transmitted from center to center. And of course, again, a good statistical analysis. What will a health record include? Anything that has to do with the medical care of the patient, the physical examination, the vital signs. Is the patient growing? Medical history, the past events, family history, the present condition, all the laboratory results, and the social history. So it's a very complex medical record, and data come from a variety of sources. They will come to the Thalassaemia Center from specialized examinations in a tertiary hospital, from specialists like the cardiologist, the endocrinologist, the liver specialist, laboratory data, including images, all converge and are collected in the medical record within the Thalassaemia Treatment Center. And just to give you some examples of screens, this is an old screen from one of our older thalassemia records. This is the transfusion card, which will give us the hemoglobin. It will give us how much blood has been transfused, chelation data, and media support, which can actually show us MRI results, X-ray results, and others which are useful in consultations. Specialist records, when the patient sees a cardiologist, echocardiographic data will actually come to the patient's record, even though probably the cardiologist saw the patient routinely, remotely. So the electronic medical record can actually help the patient, the doctor, follow guidelines and standards. It's in the nature of data gathering and the way data are entered that it can help decision support and maintain a kind of standard of patient care. This is one of the most useful aspects. There are other aspects. For example, a patient health record, and the Thalassaemia International Federation has actually developed mobile apps which allow patient health records and which can help guide the patient as to how they're doing and communicate with the health care provider. Technology can nowadays help the clinician monitor the patient from a distance. Not very frequently used at present, but this is something which will help. For example, a patient with arrhythmias needs to be followed with Holter technology for 24 hours. This can be done remotely and recorded within the patient health record and keep both the hematologist and the cardiologist informed as to how this patient is doing. We have spoken about networking, and networking has many aspects. First of all, the health record must be able to communicate with the general hospital system. Why? Because we need to import, for example, laboratory data. We need to import and use the hospital pharmacy. We need to be able to order blood through the health information system. We need to be able to communicate, as I said before, with the peripheral center and the reference center. We need to be able to do video conferencing, telemedicine, all these aspects that will help to improve patient management. And of course, there is a huge role in education. Information systems, video conferencing, we have spoken about this again, but most certainly there is a very important role of the health record and its connections, especially with databases, international databases, to help both the physician and the patient to help them to maintain standards. Can you imagine a thalassemia patient who is born today and is expected to live for 50 years? How much data is going to be collected? It's going to be a huge volume, and it's growing, and it should be growing exponentially. Therefore, big data analytics will come. Imagine some clinics that we know have about 1,000 patients. If these patients are actually going to grow, then we're going to accumulate an awful lot of data that are going to be needed. What are the challenges? Well, one of them is high costs of such systems, and there is very often a lack of adequate financial support. There is a low level of participation because there is a lot of worry between, especially among doctors, about data entry. The IT culture has not been properly developed, and I know from personal experience that over the years we've been trying to introduce these systems and they just don't come in. And we need data quality, including varying terminology. Some people use one set of terminologies, others another, and data becomes confused. So the quality of data, again, is important. There are many players as far as registries and electronic health records are concerned. They include the doctors, the patients, the regulatory bodies, industry, researchers. These are all a complex communication system which has to be considered when we're developing. I want to encourage you to adopt a patient registry at least, and certainly if you can, a disease-specific health record. Thank you.